Good afternoon. We appreciate you being here today. Thank you so much. We're going to start by calling the roll. And Dr. Cheek's going to fill in for Dr. Taylor for us.
Okay. Dr. Mercer?
Here.
Dr. Curran?
Here.
Dr. Taylor? Dr. Rodriguez?
Here.
Myself, Dr. Cheek is here. Dr. Williams? Mr. Halpert?
Here.
Major General Thomas Carden? And Dr. White?
Here. Thank you so much. We're happy to welcome Dr. White. I'm sure you'll have an introduction later regarding Dr. White. We are glad to have a new member of our board. We were given the minutes earlier. Can we have a motion to approve those minutes?
Motion we approve the minutes.
All in favor?
Aye.
Thank you. Good. Dr. Kinney?
Yes, thank you. We have a packed agenda today, so I just have a few critical things I just wanted to briefly talk about. One, first and foremost, I wanted to welcome Dr. White to the board. Dr. White is a general surgeon, resides in McDonough, and has been very, very, is very, very interested in public health. I really appreciated talking about some of the issues that we have, and I think we will enjoy working with you. And so it's just a pleasure to meet you and to welcome you to the DPH board. So thank you.
Thank you.
I also had another introduction to make. I wanted to introduce Ms. Roz Bacon. You've heard me talk about her. Roz has been appointed Chief of Staff. She's somebody that I've talked about with you before. She's has had a long, nearly a 30-year history in public health, including especially in the maternal and child health arena. And was head of the family health branch, which included maternal and child health, as well as the WIC program. Was my deputy when I was here at the state office the first time. Was deputy of Clayton County, deputy of Fulton County, and now chief of staff here. And so what I think the remarkable history of leadership she's had in public health really is a personal value at this time, but also the fact that she represents both the district and the state public health and knows how to traverse all that work. And so we are just really very, very grateful that we were able to twist her arm to come join us at the state. And so I just wanted her to have a chance to meet you. Also, since we last met, we have received on July 1st $1.5 million directed to DeKalb County to eliminate HIV. This was, we didn't know it was going to be coming to DeKalb County. We had a fairly tight time frame to write our grant application, what we were doing, but pulled in many partners as well as community-based organizations, and we hope this is the first tranche of what will be considerable amount of additional new monies for HIV. And what we're hoping to do with this program is to create a model of optimal HIV prevention, treatment, and care that can then be directed to other parts of the state, not just rural, not just urban Georgia, but also rural Georgia, and truly eliminate HIV, which is our goal. And so this is a long-term commitment, but a very important one. And last but not least, I wanted to point out in your packets the maternal and infant mortality reports, 2 reports hot off the press, which represent some of the best epidemiologic work that we have to outlining the significant problems we have in those areas and the potential for impact that we have as we strengthen our perinatal programs. And I won't talk longer because there's some important discussions to be had today about perinatal care. But I just want to thank you again for being here, and particularly thank Dr. White for his commitment to the board. Thank you.
Thank you, Dr. Feeny. So Ms. Cox, let's hear about perinatal care.
Hi, good afternoon. My name is Katie Kopp. I've presented to you all before in my previous role in government relations. Since then, I've moved into a programmatic role in women's health. Thank you. Thank you. Which is really where my heart is in women's health, so I'm super glad to be here sharing this with you all this afternoon. And before I get started, I have to say this has been a really collaborative effort between many different partners, but I do want to especially recognize Dr. Rodriguez. He's been really indispensable in this, and I invite you to interrupt me at any point and add your own thoughts. So I wanted to just start with the idea of risk-appropriate care, because I think that this is really important when we're talking about perinatal levels of care, that we're not saying that for every patient the highest level of care is the most appropriate, but we really are talking about care that is appropriate for the particular risk of that woman and of that infant. And I think that that's a really important concept that we've wanted to lead with. We haven't wanted to see this as, saying everyone needs to go to a level 3 and we're just trying to shut down the smaller hospitals. Very much the opposite, just how do we get patients to the right place. And I did also want to point out this has obviously been well documented in the literature for very low birth weight infants in particular, that they have much better outcomes when they're born in a facility that's best able to care for their needs, which in perinatal care would be a level 3 hospital. This is backwards from our other designation programs, where a level 1 would be the highest level of care, and this one it's a level 3, so I did want to note that. And I'm saying levels of perinatal care, it's really levels of maternal and neonatal care. In some ways, these are two separate things. Levels of maternal care are much newer. The American ACOG and SMFM are the leading authorities on this. Their guidelines were just published in 2015 for the first time. So this is much newer. We're one of the first states implementing this, which is really exciting for Georgia. They are working on a revision that will be released in 2019, and that's, as I understand it, the end of the summer. I don't know when that is exactly, but end of the summer 2019. And in it they go through, they have levels 1 through 4, and that's important. I'll come back to that later. Levels of neonatal care are obviously overseen by the American Academy of Pediatrics. This has been around since the 1970s, with their most recent version published in 2012. This is also, they also have levels 1 through 4. So in Georgia, we've had a version of this through the Certificate of Need program under the Department of Community Health. They have, they give a Certificate of Need for a hospital to provide perinatal services at a level 1, 2, or 3. And this is why I say that 1 through 4 is important, because in Georgia we've been recognizing levels 1 through 3 really, with our level 4s being the regional perinatal centers, and that not necessarily meaning that they're providing more intensive services than another level 3, but they're doing that additional outreach and education, and they're the designated hospital in their region to take the babies and moms that have been transferred or transported to them. In the Certificate of Need program, the emphasis is really on neonatal care with some maternal requirements. So it is perinatal in a sense, but with more of an emphasis on neonatal. And then I also wanted to emphasize that the purpose of this program is for health planning. So this program isn't quite so much to say, does this hospital have everything in place to be providing a but more, is there a need in that region for that service? So there's requirements that go along with that, but the primary focus of that program is for health planning. And I should say too, the Department of Community Health has been wonderful partners with us on this. So I wanted to give you a sense of where the birthing hospitals are at in Georgia, and I apologize if this is hard to read. I can send out a more clear version to you via email. But it's actually pretty split between the birthing hospitals, between the Holtz 1, 2, and 3 through the CON program, and then again with the 6 regional perinatal centers. So there's 75 birthing hospitals right now that are providing, that have an open labor and delivery unit. There's more that have been given a certificate of need, but they may not be providing those services, and this is also not including military hospitals. And then there's a map there, kind of showing you where they're located throughout the state, and I find this map helpful because you can see there's a high concentration of level 3s in the Atlanta region, as you would expect, and then you see throughout the rest of the state, you really have that one regional perinatal center that's supporting level 2s and 3s, and then obviously in the Augusta region, there's a large gap in obstetrical care. So one thing that we did in Georgia, and I have on here 2017, it should be 2016, my apologies for that. We implemented the levels of care assessment tool developed by CDC. And the purpose of this tool is to say, okay, what capabilities do you actually have in your facility, and match it up with what ACOG and what AAP are saying are the requirements for that level of care. So it's a survey, it's an assessment tool. We are, you can see one of just a few states that have implemented it, so CDC is really proud of this. When we look at the results from it, about half of the facilities, half of the birthing hospitals in Georgia who participated in the survey, which was almost all of them, were matching, what they have through CON was matching what they were assessing as through the locate tool. And for neonatal, about 50% were lower than what their CON has them as, and for maternal it was 44%. So this is really important data. And I would say that based off of this, it's not like most of the hospitals were so far away from meeting all of the requirements from their level of care through CON. There was probably just a few areas of deficiency that were keeping them from fully matching. The locate tool uses really rigid criteria for it. There's not a lot of flexibility in that. So based off of this, we established a voluntary designation program for birthing centers that has several goals. One of them is to separate the designations from maternal and neonatal centers. I said that hospitals in Georgia have been recognized. They've been given through their licensure, they have a perinatal level of care that's really focused on neonatal level of care. This separates it out, and it's recognizing them and assessing them on maternal and neonatal because they are separate. It also is a program that are using requirements that are based off of the most recent AAP and ACOG guidelines. So of course we've been working with the ones that ACOG released initially, but we will plan to revise it when ACOG releases their newest guidelines. And I've been working with them, and they've been helpful in pointing us in the right direction, so there shouldn't be too many changes. And then it also ensures an ongoing on-site verification every 3 years. So this is really important. This is kind of the piece that's been missing, is we haven't had the ability to go in and regularly assess. As you can imagine, over time, your staffing levels changes. And so this is really important to be able to have that ongoing verification process. And then the last piece that's really important is that the site surveys are really designed to provide consultation to hospitals too. So this isn't intended to be overly punitive, but we really want to be able to provide support to these hospitals is where Dr. Rodriguez has been super helpful. He was the neonatologist that helped lead this work. We also had an MFM, a nursing representative, the Georgia chapter of AAP has been super helpful, as well as the OBGYN Society, and like I said, the Department of Community Health. They've been overseeing the entire program, but underneath that we had two subcommittees, one for maternal and one for neonatal. And this had about 20 members each, a bunch of physicians, hospital administrators, nurses, people who, they really got into the leads on this, and we tried to make sure that there was good urban and rural representation from different hospital systems, and they really worked on what the requirements in Georgia looked like. So I wanted to present just an overview of what they came up with, and I also am happy to share via email the full draft that we're working with right now. It's in the public comment period, so it's not quite final, but it matches what ACOG and AAP have very, very closely. So for maternal levels of care, so a level 1 is really just, they provide basic care in uncomplicated pregnancies. The real requirement is that you can do anesthesia, and then you have an OB available for, or an obstetric provider, available for an emergency cesarean. When you get into level 2, this is looking a little bit more at specialty care, and you have an OB available to be on site and an MFM for consultation, and yeah, the surgical consultants available. I don't want to read it all to you, you can see it there. And then the level 3 obviously being more complex, where you have an OB on site at all time, and an MFM with inpatient privileges. And then the neonatal centers, and again, this matches very closely with what AAP has. There's not many differences. And I should have said too, we had ACOG and AAP reviewing all of this as well, and they provided their feedback on it. So the main thing here is that once you get to level 2, you have a neonatologist available for consultation. At level 3 is where you have more of the specialty providers. So some of the considerations, and I phrase this considerations because depending who you are, this is your favorite part or this is your least favorite part, because either it goes too far or doesn't go far enough. But this is a voluntary program, so hospitals do not have to participate in this. We feel like there's a lot of interest from hospitals to apply, and we anticipate good participation, but it is voluntary. Also, their certificate of need will not change. So essentially, hospitals will need to apply to us under the level that they've been authorized through the certificate of need program, and in a sense will be verifying what they've been licensed to provide through CON. And this is where, again, I say that levels 1 through 3 is really important, because since we don't recognize a level 4 as AAP and ACOG define it, in the certificate of need program, we're not going to recognize it in our program. It would have opened up a new category of CON, and we've tried to be really careful not to mess with hospitals' certificate of need in this. So, the way I kind of think about it is it's really a verification and somewhat of a gold star. Like you are allowed to provide the service. DCH has determined that there's a need in this area, and then we're going to go in and confirm that, and yes, you really do have everything that you would need to provide this service based off of AAP and ACOG's recommendations that we've sort of adapted for Georgia. So the designation process that we're going to be using is fairly straightforward and similar to our other programs. Hospitals will submit a pre-review questionnaire, and then they'll participate in a site survey. For neonatal center designations, this will be conducted by AAP. They started their verification program in Texas, and I don't know who, but I know that they're rolling it out to other states, but we'll be among the first that they're going to be doing this in outside of Texas. And then similar to the maternal center designations, we'll be using about half the cost for the hospitals. So they'll only pay $7,000 for one site survey, so if they wanted to do maternal and neonatal, they would pay $14,000 every 3 years, which we feel like is really reasonable, to again be able to have that consultation service from leading authorities on this. We think that's really important. So that's how we've structured this. And then the site survey report that's done by the survey organization will be sent to DPH. We will review it. They'll have an opportunity to address any deficiencies that there are, and then the final determination will come from our commissioner. And then there is also an appeals process in place. So the timeline for this is soon. As I said, it's in the public comment period. So if we make any changes to that, we'll start that period over again. And we have in the past few days gotten some comments that we'll look at. So yes, but AAP on the neonatal side is ready to go whenever we are. So with that, I'm happy to take any questions.
So, just a question, a
Yeah.
wonderful report, and I'm glad we're doing this in the state. But if I was a hospital and I wanted a different designation, since you said you're going to keep it the same, so I'd have to go back and get my certificate of need. I'd have to go back to DCH if I wanted to
Correct.
get
Yeah.
a different designation.
Correct. Yeah. In a technical sense, like I'm not counting this as a category because I just don't think anyone will do it realistically. But like if you have a CON at a level 3 and you kind of look at it and you think, we're really a level 2, you could apply to us under that level. We just can't recognize a hospital for going outside of their certificate of need, which is why they can't be bumped up in that sense. But they could go through the Department of Community Health, get a new certificate of need, and then come to us.
On slide 9, where you show the level assessment discrepancies,
Yeah.
I want to make sure I have that right. So that third line down where it says locate lower than CON, is that meaning that 50% of the centers, neonatal centers, are actually functioning at a level lower than they're designated or self-designated?
That's correct. Yeah.
And so is there something to be done about that, or everyone will fall into this process? Because if you're holding yourself out as a level 3 nursery but not functioning as one, that could be a problem, I think.
Yeah. And this is where I would say, some would say it doesn't go far enough, right? And that's a little bit outside of my scope to address that.
Right.
I think that for most hospitals, when we look at the data, they weren't so far away from being able to become a true level 3, if you will. Like there could be things that would be pretty simple to put in place. Most of them had 1 or 2 areas. So the hope would be that this is an incentive to get that in place and really be meeting all of the requirements. So I wouldn't look at that as 50% have no shot at becoming, meeting all the requirements for a level 3 and are operating that way, but that most of those hospitals, there's just a few things that they would need, a few like consultations that they
Right.
would need.
And I assume the designation process being recommended would then point those issues out and the action plan would come to that,
Exactly.
much like we do with trauma.
Let me ask, this will probably go to Dr. Rodriguez. And if you go back to our map on slide 7, where we have the density of the level 3s, primarily in North Georgia, Atlanta area, I thought our problems with level 3s had to do with our MFMs. I mean, the availability in our state. I didn't realize we would have that many designated as level 3s in the metro area.
You mean for the neonatal units that are designated as level 3?
Or just with the birthing hospitals,
Correct.
all these birthing hospitals, yeah.
So part of, first of all, I'd like to commend both Katie and Diane for the hard work in herding cats, because
Right,
for
yeah.
the most part,
Yeah,
this was
absolutely.
herding cats, when you talk about 3 separate committees and trying to get all this information and
Absolutely.
getting this out there. And the baseline of this is essentially trying to get us to a point where infant mortality and maternal mortality are addressed. And this is not the solution for all those problems, but it does stand as a great first step. And with that said, the issue that you're describing is identifying those NICUs that potentially may be operating outside of the scope of care and bringing them to the table and saying, okay, this is what you should be doing and how can we get you there, not necessarily limiting that care. When you look at the Atlanta area, it's a much denser population area, so it stands to reason that you're gonna have a lot more level 3s in that area because of the population in that area. As you go outside of the metro area, you're basically dependent for the most part on the regional centers to provide that care in that respect. So hopefully with that said, as we move forward, because one of the things that Katie talked about with these very low, extremely low birth weight babies or very low birth weight babies, those babies, the mortality is higher when they're not delivered in a level 3 center. But we're also looking at saying that all our centers that are currently level 3 are not necessarily level 3s, as you identified with the locate. So there's no transparency here for somebody that's going to deliver a child that says, well, I'm going to go to a level 3 center. There's no way of knowing about what capacity or capabilities they're operating on. This would give that transparency to the public to know, because not only are we speaking of mortality, but we're also talking about morbidity, which is probably the big aspect. And part of this whole package, which Katie didn't have an opportunity to mention, is that we will be collecting data. One of the requirements on all maternal and neonatal centers is to participate in not only CQI projects, quality improvement projects, but also participate in a data submission program so we can monitor and at least see from a standpoint of statewide how we're doing in that respect.
Would an institution be able to find out from you directly if they underscored or underdesignated or overdesignated on the locate tool?
Yes, they all have their results.
Oh, okay.
So they were sent their results, we were sent their results, we only reported out in aggregate form, but they have that information.
So our perinatal centers in Georgia are Augusta, Columbus, Grady, Macon. Is that Albany? Is that
Albany
Albany's
and
fifth one.
Savannah.
Yeah.
Okay, Savannah, okay, great.
Good job.
Okay, and so these are going to then be labeled zones, is that correct? Am I correct? So we have our regional perinatal centers.
Correct.
And are then these centers going to have a geographic area that they are
Currently, based on when the levels of care and the first regional perinatal centers were established, I think in the 70s, and there were 5, and then Albany was added in the 90s. These perinatal centers were divided in counties in the state.
Okay.
So that we're not addressing that issue at this
Right
point in
now,
time.
okay.
The geographical location and at the time the maps were a little bit different than they are now, as you can imagine, population growth, but that's not part of the scope of this,
Okay.
of this program.
All right. Thank you so much.
Very well done.
Yeah, very well done. It is
Thank
very
you.
catch. Thank you for starting this. We look forward to many more reports on this.
Thank you very much.
Dr. Trinity.
Great pleasure to be with you again this afternoon. You get to hear me give another brief update about our 2 favorite infectious diseases. They might not be my favorites for very long. A little tired of them. So I want to take this opportunity this afternoon to give you a brief update about our hepatitis A outbreak in Georgia. And I want to talk a little bit about measles, both nationally and also here in Georgia as well. And then we will have some time for questions. So first of all, let's take a look at where we are in regards to the hepatitis A outbreak in Georgia. So we're actually about a year into the outbreak now. The outbreak began in the beginning of June of last year. And the data on the slide in front of you are reflective of the end of June now. So we're about a year in, and we've documented 468 confirmed cases of hepatitis A virus infection in Georgia. Since the last time you saw me, which we skipped a month, but that's an increase of 170 cases since I was here last time. The epidemiology of the outbreak itself has not changed. in regards to the median age of case patients. Again, 45 years of age, predominantly male, predominantly white, and a very, very high level of hospitalizations due to their infections. Again, about 68% of our cases have been hospitalized. This has been consistent throughout the entire year of the outbreak. We also have had 2 fatal cases of hepatitis A virus infection in Georgia during this year of our outbreak. And again, what I want to highlight as we're here at 468 cases is that if you look at the epi curve and you sort of look at the months of, again, March, April, May, and even June, again, we might actually be somewhat lulled into thinking that we're relatively stable, or at least it's not exploding. So I want to again make the case that we should never be lulled into any sense of complacency here. We've learned from our partners at CDC that have a lot of experience with other states in these large hepatitis A outbreaks, is that once the outbreak hits about 400 cases or so, they have a tendency and a propensity to explode dramatically from 400 to 2,000, again, relatively rapidly. So we have been, again, promoting this message that we can't let up, we cannot think that we're doing okay, that again, we have to continue, again, to follow the epidemiology of this outbreak to drive our prevention in the population at risk. So let me show you that in a little more detail. So geographically, again, the outbreak here in Georgia has not changed a lot. Again, we have hot spots in the same areas of the state. If you look at these maps, again, the map on my left is the counts, and the map on the right are the rates. So again, our hot spots clearly are Northwest Georgia, the Rome area, the Augusta area, and again, Metro Atlanta, primarily Fulton County as well. So again, this has not been different throughout. We do not have like this huge, sort of rapid spread across the state. The hot spots have remained consistent. However, they really have not, again, they are not really going down in regards to counts or rates as well. So again, we're still continuing to see increases in these areas. And so again, we're sort of using, again, our epidemiology to drive this. If you break down our case numbers by district, kind of translating that map to each and every health district, you can see here there is great disparity. Certainly, again, we have over 200 cases, again, almost half, more than half of ours, almost half of our cases in the Rome district alone during this year. And our Augusta Health District has also, again, moved into second place and has remained there pretty consistently as well. Both of these areas of our state are, again, are characterized by the fact that there are very large hepatitis outbreaks ongoing across their borders in other states. So the Rome District, again, was a recipient of the huge hepatitis A outbreak that was in Chattanooga that started there and spread to Rome. And our Augusta district now is also, again, being directly impacted by large hepatitis A outbreaks in South Carolina, particularly in the Aiken area. So again, they don't really respect state borders, but that's why we're seeing these concentrations here. One other thing that I want to mention is that our neighboring state of Florida actually, again, has well over 2,000 cases of hepatitis A infection. And again, as of the end of last year, so in a period of 7 months or so, they really went from like 350 cases to over 2,000 really rapidly. That's why, again, I'm promoting no complacency here. We have to stay on top of this. So even our southern districts, again, in Georgia, as you may see here, so for example, like our Valdosta district, may have a single case that we've documented so far. Again, I don't want them to, again, assume that it may not, kind of come up and spread upward from Florida as well. Most of the Florida cases have been in the Tampa area, central Florida. primarily, not really at their north border. But with 2,000 cases, it can spread anywhere in that state too. I just wanted to take a moment and show you like an individual district and their case counts by week. This epi curve, again, it may be a little difficult to see the weeks, but I'll sort of guide you through it. This is, I think it's really telling. So this is our Augusta district. And if you really start to see where the peaks begin, their outbreak began in the beginning of the year. The highest peaks that you see in yellow, which are in Richmond County, that's the county where Augusta city proper sits. Their peak levels of activity were primarily in April, mid-April or so, down a little bit, up a little bit. And what I want really to highlight here is that it's been very consistent. We've been kind of consistently have cases through week after week after week. And again, we're starting to see some decreases, perhaps. Sometimes these cases are reported a little late and they get counted a little late. But I'm glad to see that we're seeing some decreases. Our partners and our health departments have, and you'll hear about this in a minute, have been working very hard to try to, again, vaccinate the populations at risk. So I thought that perhaps showing you this by week might be a good indication of how we approach an individual district and try to sort of tailor our response based on that epidemiology. So when we think about the population at risk, this also hasn't changed at all throughout this outbreak. The population at risk for, the vast majority of our outbreak is drug use, illicit drug use, both injection drug and non-injection drug use. So half of our cases report drug use. Again, the other risk factors that we have documented, of course, are contacts to confirmed cases and also MSM as well, primarily in the metro Atlanta area. So how do we reach this population at risk? That's been our overarching response strategy. And again, as I had mentioned before, we're using an incident command structure to try to coordinate this at a high level. But we really are trying to target, our population at risk, which we've, decided to strategize and focus by offering vaccine, hepatitis A vaccine, in county jails. And our health departments and our district health offices have been doing a tremendous amount of outreach to county jails. Because this will cover, folks that are in county jails often are, in the community, in the jail setting, back and forth. And again, having them vaccinated, offers this level of protection and we found to be one of the best ways to reach the population at risk, which is inherently very difficult to reach. And a parallel response strategy is also, in the healthcare provider community, providing education about our risk factors, about the outbreak, about screening for risk factors, and offering vaccination to those at risk, and how to report to public health as well. And we focused on our emergency departments in that way as well. So let me show you a little bit about how we're doing. I realize that this scorecard is not easy to read. It's really just for effect to show you that we are essentially trying to keep track by our health districts as to, in their vaccination outreaches, how are they doing reaching our population at risk? How are they doing offering vaccine in jail settings, in substance abuse centers, to contacts of other cases? And if you look at it, our health departments have given, actually as of this week, more than 6,000 hepatitis A vaccines. About half of them or so have been to contacts of known cases, but we're really starting to increase and ramp up our number of vaccines given in these jail settings and other higher risk settings as well. We need to continue to do so with as many innovative ways as possible. And we've had individual calls with each of our health districts to try to, share information, gain knowledge about their best and creative practices to try to reach this, population at risk. All right, so here's number 2. You've heard this one before as well. I wanted to give you a little update about measles, both nationally and here in Georgia. So nationally, the measles picture is very different than it's been in more than 25 years. So as of this year, since the beginning of 2019, 1,095 measles cases have been documented in the U.S., by far the highest number that we've seen here since 1992. And if you look at the graph on the slide, again, our 2019 numbers really essentially triple what was documented in all of last year. So again, the picture nationally is very stark in regards to these high numbers of measles cases that are primarily being driven by 4 huge ongoing outbreaks. 2 of them in New York City primarily, 1 in California, and 1 in Washington. All 4 of these outbreaks have occurred among very close-knit communities, close-knit in the sense of either being religious communities or of certain ethnic backgrounds. So again, the outbreaks in New York City are huge. They really comprise almost, or more than half of the national cases that have been reported. The median age of sort of all of these measles cases nationally, these 1,000+ cases, is 5 years of age. So they're mostly among kids, vast majority unvaccinated. And so what we're seeing, again, in these outbreaks that are in these close-knit communities is that there are, again, large pockets of either under-vaccinated or unvaccinated individuals. And again, it allows for sort of rapid spread and even spread outside of these close-knit communities to others. So that's been the epidemiologic pattern nationally. That has not been different as well. Most of our, again, measles cases and outbreaks here in the U.S. have started with a traveler to an area of the world where measles is circulating at high levels. They bring their infection back here to the U.S. and in fact back to these close-knit communities, resulting in further spread because of the pockets of under-vaccination, if you will. So what have we seen here in Georgia? We've actually seen sort of a mini version of all of that as well. Luckily not at that scale. But we're talking about, have we had any measles outbreaks here in Georgia this year? The answer is yes. We've actually had two very small measles outbreaks in Georgia. The CDC defines a measles outbreak as having 3 cases of measles that are related in place at time. We actually had 2 of 3 cases each. They were both single families. One was in January, one was in April. Again, these all involved unvaccinated children that were in the same families. And they also started or originated from travel to areas where measles was circulating. So those were our 2 outbreaks. You've heard about those before. But the new one that you haven't heard about yet is that we actually documented a single confirmed case of measles in late June as well. So this was a single individual and was also unvaccinated and also was an international traveler. So with this single case, our grand total of measles cases in Georgia so far this year is 7. So what happened with our most recent measles case? Let's take a quick look at that. On June 20th, our Georgia Public Health Laboratory confirmed measles infection in an unvaccinated teenager who had recently traveled to Europe. So once we heard again about this measles case, for us, of course, it's a public health emergency. It's all hands on deck, and the investigation goals really are to try to very, very rapidly identify any exposed contacts so that we can stop the spread of measles. So if we want to identify anybody that might have been exposed to this individual, and particularly any individuals that may be susceptible or still susceptible to measles, so that we can offer them prophylaxis as appropriate, whether it's measles vaccine or immune globulin within a certain time frame to prevent them from getting measles, and also to notify them, hey, you've been exposed to measles, and if you work or go to school or in daycare at a high-risk environment, we would like to exclude you from this environment during the incubation period and monitor your health to see if indeed, if there is high risk, that you don't spread this to others. So those are the goals of any measles investigation. And one of the things that I'm proud to talk about and tell you a little bit about, and I would like to again thank publicly our Carl Sodebeer and our Office of Informatics and also our SENS team They assisted us in developing, and we really used it for the first time in earnest during this measles investigation, an electronic, web-based measles contact tracing module. So that it really is the central place where we can track every single person that we've identified as being exposed to the measles case, and we're able to, again, to provide essentially an algorithm for whatever goes on in this investigation from step 1 to step 10, meaning are they immune? What is their risk status? Is there any prophy needed? Is there follow-up monitoring needed? And we have it all in one place. So I'm just going to show you a couple of really quick screenshots, and we're tremendously thankful for this tool. It's been a great improvement in the efficiency that we can all have. We can have several epidemiologists, again, working all of this at the same time in the same place centrally, entering all these data. We can follow it all essentially in real time. It's been great. So again, just briefly, I'll just show you without going into a lot of detail. We really start out with, hey, here's a way to track the contact, do the phone interview, how many times have you tried to call, here's the phone script to tell the person, hey, you've been potentially exposed to measles, are you immune? And we go through essentially the questions. Are you already currently vaccinated? Are you up to date on your vaccinations? Were you born before 1957? All of this documents immunity. It documents the risk assessment, meaning do any of these exposed individuals actually work in a daycare, are pregnant women, are immune compromised? So that, again, we want to really prioritize these high-risk individuals so they can get prophy right away, and they are the priority of the investigation, or they can be excluded from the high-risk environment if need be as well. And then after that, we determine, hey, do you need IG? Do you need a vaccine? What are the dates that were given? Is it high risk? Is it low risk? And then if not, if there's a susceptible individual, for example, that's beyond the window for prophy, very often we recommend what we call post-exposure monitoring, meaning at home, meaning we actually literally actively call this household every day in the incubation period to say, hey, this infant who is too young to be vaccinated, we want to make sure that the infant does not develop symptoms of measles, does not show up in the emergency room or the urgent care center, so we actually follow them, and we have a way to track this electronically now, so we're very happy about that. So thanks, Carl, if you're in here. Also, I just wanted to just tell you, sort of in this most recent measles case, it was pretty contained, luckily. We identified less than 50 total contacts for this individual, and only 2 of them were actually susceptible. Both were unvaccinated children. So we recommended that they remained at home, excluded from their school or daycare, and and health department epidemiologists called them each and every day. And luckily, they didn't develop symptoms of measles, and we had no secondary measles cases identified from this one, luckily. So what are really the implications, or really the bottom line by, again, telling you how not only how we investigate a measles case, but the big picture for us all really, again, is this reminder about travel. So Europe is experiencing extremely high measles activity, including record numbers of measles deaths. Measles can indeed be a very, very serious and severe clinical infection. 2 weeks ago or so now, CDC authors published a paper in Pediatrics, really that, and an affiliated alert that really was a reminder about international travel, particularly Europe. But really, I propose all international travelers really should be reminded that they be fully up to date on MMR before they travel. And really, when we're thinking about infants younger than 12 months who are really too young to receive full vaccination or too young to receive their MMR, they really are the ones that are at greatest risk of severe infections. So we really want to be very careful and take good care of them as well in regards to their international travel. So the CDC recommendations now that they were reminding folks, again, and this is not really particularly a change, it's just a reminder to say, any infants that are traveling internationally, the infants that are 6 months through 11 months, again, should receive 1 dose of MMR. It's an early dose, so it's before they usually get it, and they should get it at least 2 weeks before they travel. Simply because, again, there's so much measles activity around the world. And we also are getting a lot of questions about domestic travel. So for infants that are traveling here in the US to areas that have either experienced measles outbreaks or even these ongoing ones like in New York City, there's not a blanket recommendation that infants, again, that are traveling domestically receive an early MMR dose in all situations, but it should be considered if they're visiting areas in, again, outbreaks that have had these close-knit community outbreaks that have demonstrated very ongoing, kind of community-wide transmission. So it indeed can and should be considered in these settings as well. And that's it for me for today. I'm happy to entertain any questions that you might have.
So back on HIV, couple of questions.
Sure.
You pointed out that in Rome and Augusta, these were due to outbreaks and bleed over from Chattanooga and Aiken. Do we know what was going on or is going on in Chattanooga and Aiken?
Yeah, it's a really good question. So again, these were how they really originated, and mostly, again, the epidemiology of these hepatitis A outbreaks have been similar across the board. So again, the outbreaks in Tennessee, the outbreaks in South Carolina, and the outbreak in Florida really mirrors ours. It mirrors ours in regards to the epidemiology and the risk factors as well. Again, it's just that again, these outbreaks in these states, again, were larger than ours. They spread, kind of more rapidly, and they essentially kind of spilled over the border. But again, the sort of root causes and the populations at risk in our neighboring states are the same as ours. They're just a notoriously difficult population to reach.
So IV drug use, right?
IV drug use, non-injection drug use as well.
Okay, and then also the contact from a confirmed case what is a significant portion of that related to food handling or just general contact?
So it is actually most of the confirmed hepatitis A cases. We really don't, although we respond to certainly and do a risk assessment for any infected food handler, the risk really of hepatitis A transmission through food and from an infected food handler is really very, very low. So most of these contacts are household contacts or close contacts either in jail settings or other sort of congregate type settings. What we've seen, again, this is just a snapshot of some of the epidemiology, but when we mean a close contact, we've seen individuals, again, that may share a house. Again, it may be a whole, large group of them in fact, but they're all in the same household, and, sort of one gets infected first, and they either are in close physical contact, or they may share risk factors, of drug use as well, so.
So I understand the Fulton County issue is a significant homeless shelter issue potentially?
In what we've seen in Metro Atlanta, which is a slightly different epidemiology than other parts of the state, is that, again, we've seen the primary risk factor, one of the primary risk factors to be MSM, so, and a little bit of homeless, not as much,
okay.
Not as much as in some of the other states as well.
Okay.
The sort of original, really large hepatitis A outbreaks in California and Michigan were primarily among homeless populations. We've seen less of that now. It's much more drug use here and in the southeast.
The guy just left, I would have asked this question too, but with the MSM population, is there a concerted effort around vaccination through, and I should know this, but I don't, through Grady's IDP or through?
Yes, we've been working with Grady as well. Absolutely, there is a concerted effort, and also through other health department clinics, Rhineway clinics,
Okay.
HIV clinics as well. So.
Right.
And we haven't seen huge increases, again, in Metro Atlanta.
Well, and it seems like, there's been a decline over that 1 year period, but just want to make sure we're doing what we're supposed to.
Dr. Desmond, is there any contraindication if it's an undocumented situation of unknown vaccination? Are there any risk factors or reactions if the hepatitis A vaccine is repeated, having received it within the year?
Oh, if in case someone doesn't know if they've had it or not. Not to my knowledge, again, and in any case, as sort of, we can also look at, kind of one dose of vaccine versus two. One is great, two is even better, so I think that would not be a contraindication.
And when they present to the emergency rooms, is there a subset of presenting symptoms that they try to sequester groups? or what is their presenting symptom to an ER when they're hospitalized?
You know, so oftentimes, again, the symptoms of hepatitis A are really, you know, similar across the board. And, you know, very often, again, these individuals, some often present to hospitals or are hospitalized because they may have some other comorbidities, or they may have pre-existing, you know, sort of liver compromise in some way. So they're a little different than sort of the you know, sort of the routine hepatitis A virus, you know, infection. But again, the others, you know, maybe jaundice as well. But really in EDs, we also are, again, thinking about, even if they're presenting, our message is also, even if someone is there and presenting for something else entirely, if they sort of share some of these risk factors and vaccinate them while they're there, that's helpful as well.
And what are the laws in Georgia about a child being able to be unvaccinated in the school system?
So there are, again, I'm hoping that perhaps some of my immunization program colleagues are here, but we do have, we have two types of vaccine exemptions in Georgia. We don't have a philosophical exemption, but we have a medical exemption and a religious exemption.
And so they, those people that have a philosophical reason, most of the time claim the religious, it is my religion, reason that I don't.
Do we know what percentage of children are in Georgia are unvaccinated?
You mean,
In school systems, in the public?
so we would be able to, right, it would not include private schools. And so again, our vaccine coverage rates, again, in school settings, in public schools, you know, is well over 90%, you know. But again, it doesn't include, you know, homeschool,
Right.
private school, other settings too.
Excuse me, Sherry, and wasn't it true that at least one of the outbreaks was among a family that was homeschooled?
Yes.
Yeah.
Thank you so much, Dr. Dresser.
Thank you all for your
Thank
kind
you.
attention.
Very good.
Ms. Tia? This will be a new area for us. Thank you.
My pleasure. Good afternoon, Madam Chairman, members of the board, Commissioner Toomey. Good to see everyone today. I'm really excited to talk to you a little bit about this new opportunity for us at Department of Public Health. My name is Elizabeth Hatt. I'm the Deputy Director for Injury Prevention here at DPH. We're going to talk a little bit about Alzheimer's and dementia and a lot about our Think About It campaign. So, every 65 seconds, someone develops Alzheimer's disease. We know that nearly 6 million Americans have Alzheimer's disease. In Georgia, we're projected right now to be about 150,000 folks with Alzheimer's disease, with a projected increase of 27% by 2025. So the burden here is a big one, and something that we're wanting to bring awareness to is that when we think of Alzheimer's or any type of dementia, we typically think about a certain age, 65 and older, right? Younger onset can begin as young as 40, and that's something that with this campaign and through our launching work in public health that we hope to bring greater awareness to is that younger onset of the disease. The number of people living with Alzheimer's and dementia is growing. The burden is, we manage those better. They've been around for a while. We've got a lot of good programs around them. We have less with Alzheimer's and are working more towards that. And dementias, including Alzheimer's, impact all communities. We have some particular disparities among Alzheimer's patients, our African Americans and Hispanic populations. Their burden is greater, and the burden of care affects every single person that is in that circle of family and care and in the community for them. We have workforce shortages around it because there's a lack of training around how to interact with a person with any types of Alzheimer's, and we still think of it as the disease and not as a person that is having to manage everything that comes with that disease. So we really want folks to begin thinking about some of these details. And so our Department of Public Health is launching our Think About It campaign. One of the things we're going to be pushing is an annual wellness visit, which is severely underutilized across our state, really across the country, but we've got some pretty big discrepancies here across our state. We want people to know that the doctor may ask if you get lost. Do you have problems with numbers? Do Do you have difficulty shopping for things by yourself? Your doctor, we want people to know what the doctor may ask. And we want doctors to be asking these questions, right? And then we want folks to reduce the risk that they have for any type of Alzheimer's or related dementia. So, I do want to say that we are so excited to launch this, and we're going to look at this first amazing graphic. This would not be possible without our amazing communications team. Nancy Neidem and her team, with really fantastic support and funding from Alzheimer's Association, have come up with this campaign. A couple of us as subject matter experts contributed to it, but these graphics are all communications, and they've done a fabulous job with it. So think about it for a moment. Have you gotten lost at going to the grocery store again? Now, who here's ever gotten lost or taken a wrong turn? Everybody raise your hand if y'all know you have, okay? But do you think about why you got lost, right? That's normal. We've got too much going on. The kid was sick this morning. Got to deal with stuff after work. Your ability to retrace your steps and think about the why of it is what's important here. When you suddenly wind up 2 hours away and you're not sure how you got there and you don't know why you're there and you're pretty sure you're where you're supposed to be, that's what we're talking about. So we want folks to think about that getting lost. We want everyone to think about making the numbers add up. Do you have trouble writing checks? This is particularly poignant for our older population. We're getting a little bit away from the writing checks right now, right? This digital age. But do you have trouble thinking about numbers? Do you have trouble with any type of number you deal with? Can you remember your address? Do you know what year it is? You might not want to know what year it is, depending on what kind of year you're having. But if you really, truly have trouble recalling that, we want you to think about that, and maybe it's time to have a conversation with your doctor. Can you not find the correct word? If I hadn't eaten lunch before I came here today, I would really be having trouble finding the right words to talk with you. But I ate food, and I know that that's a thing for me. Everyone occasionally has trouble with that. But what we really see with dementia, with Alzheimer's, any of those diseases, not only can they not connect and find the right word just to complete a sentence, but they begin to withdraw from normal everyday activities. Your normally social person is no longer social. And that withdrawal, that inability to connect, that sometimes even fear around connecting, can be an indicator. And we want folks to think about it and maybe ask a question of their doctor and of their family members so that they can talk about it. So where will we see, I'm going to go back to this, where will we see these graphics? We're going to see them everywhere. They're going to be on MARTA. They're going to be in your folders from today. We have these amazing little postcards that could be handed out with the how to reduce your risk and think about it factors on the back. Those are there for your enjoyment and myself, quite frankly. We want to see these on billboards, particularly in our rural areas that are harder to reach. We hope to see these at a Braves game one day and then working on it. So those are the types of places that we're going to see, and this launches a larger effort and quite frankly supports a continuing effort. But our partners at the Alzheimer's Association here in Georgia and our partners in the Aging Network, particularly the Division of Aging Services, have been working on for a long time. Traditionally, our public health role is surveillance, monitoring, data, and we have that. You know, I'll talk about the Georgia Alzheimer's and Related Dementia Task Force in just a moment. Our EPI group has partnered with them to create an Alzheimer's report in the past. It's fantastic. So we've got the data and the numbers. We're reviewing CMS data to see what that looks like in that population. So good things, right? We want to promote risk reduction, which we're doing via this campaign. We want to incorporate and complement the work that our partners are already doing so well. Where we really have an opportunity as public health is to talk with our primary care physicians around the state and really encourage the increase of the annual wellness visits and doing memory screenings at those annual wellness visits. It's a huge opportunity using these materials or other materials. We want to look at warning signs for dementia. Yes, sir.
When you say wellness visit, are you talking about the Medicare
Yes,
funded
sir, I
wellness
am.
visit? Okay.
The Medicare appointment, well, your
Yes.
AWV. Yes, sir, absolutely. We want better training for our healthcare providers. It is not just a diagnosis, it is an introduction to care and services, which luckily a lot of our partners are very good at, trying to find services once there's a diagnosis, and continued partner support. We have in the audience for sure today Ms. Kathy Simpson, who I believe will speak in a moment. And Mary Lee Boatwright-Quinn from the Alzheimer's Association will talk to you in a few moments. But how we can support them is really important as they continue their work as well. Georgia Alzheimer's Disease and Related Dementias, the task force, or GARD, was originally created in 2014. They established some work groups which exist today. A couple of those original 6 work groups have split off into subgroups. Just as one example, the public safety work group now does some things that are more clinical and judicially related, and then the other one of that has dealt with injury topics specifically. In the 2018 legislative session, they reestablished the advisory council for GARD, and this year we're working on bylaws and officers to be established. So that work continues. We sit on some of their subcommittees and help inform with data, taking of notes, suggestions and ideas, and of course now we're thinking about a campaign. Something else that our partners are doing, where we, again, when we talk about this primary care annual wellness visit, the Georgia Memory Net has been established through Georgia legislature. That those dollars went to Department of Human Services to establish the Georgia Memory Net. Those are essentially 5 memory assessment clinics around the state, and this is essentially a process flow that you're seeing in front of you. So primary care physicians would have the wellness visit and screen for cognitive decline. They would hopefully refer them to these memory assessment clinics, where they would get in-depth, more one-on-one attention by experts in the field. They then want to connect them with proper services within the community. We want their caregivers to become involved, and again, continue to think about ways that they can help and ways that we can support them as a group. And then that cycle repeats itself as people continue to go on. We have contributed to the Brain Strong Flyers, which was created by the Alzheimer's and Related Dementia Task Force. This is a really great complementary with our website for our campaign, which is Georgia Healthy Brain and Brain Strong. So those are 2 really awesome complementary efforts. So we're all talking the same language as we're doing this. And that is really our primary goal here, is to bring everybody together and move forward as one huge partnership. Finally, Dementia Friends. Dementia Friends is actually a national organization. They have 5 key messages, which you can see in front of you. Dementia is not a normal part of aging. It's caused by diseases of the brain. It's not just about memory problems. We want good quality of life for these folks, and we want to help the person manage their disease, not look strictly at the disease. So we make it a little bit more person-centered by taking that approach. Mostly, we're really, really excited to launch this campaign, the Think About It campaign. I'd really like to give the floor, if I may, to Ms. Kathy Simpson. She's the Director of Public Policy and Advocacy with the Alzheimer's Association and has so generously funded our ability to do this campaign.
Thank you, Liz. Madam Chair, board members, and Commissioner Toomey. We are so excited for this campaign, and I'm sorry, I get a little emotional. My mother, my grandmother, 3 aunts, 4 cousins have been impacted by this disease, so it's personal. But more than that, we appreciate the support of the Georgia Department of Public Health. We appreciate the Georgia General Assembly funding the $350,000 for the campaign, and the Department of Public Health leveraging those dollars to much, much more. We appreciate the governor's support, and we appreciate the support of the Department of Human Services. I serve also as the chair of the Georgia Alzheimer's and Related Dementia State Plan Advisory Council, and we look forward to continuing this partnership. We began working with public health in 2010 with the behavioral risk factor surveillance system surveys, modules for both cognitive health and for caregivers. We look forward to working with you. Commissioner Toomey serves on the advisory council. Liz has been out to a number of different events with us, and we truly appreciate the support. We could not do it without such wonderful partnerships, so thank you very much.
Thank you.
Thank you for being here.
That's all that we have. I'd be happy to entertain any questions if you do have them.
How is Medicare funding, once the diagnosis is reached, how is the funding for medications and therapy?
Just stay up here.
So what the question is, once the diagnosis is
Once
reached?
you have the diagnosis, how is the funding? How is the funding for care, for medications, for evaluations?
Most of that is done through Medicare funding and private funding. We have been working tremendously over the years with Congress, with the Department of Health and Human Services to increase resources not only through the Department of Human Services, but at the state level. Nonprofit organizations like ours, through the Department of Human Services, through their Division of Aging Services, with Aging Disability Resource Centers. There is still much to be done. A new piece of funding coming down through the Centers for Disease Control with the Congress funded, and we're going back now for authorization of those funds for the Bold Infrastructure for Alzheimer's Act to better engage departments of public health to help planning so that those services become more available to individuals who have the need.
Any other questions? Thank you so much for your
Thank
time.
you, thank you for this new introduction. Any other questions or comments? Well, thank you so much for continuing to educate us and for this new information and keeping us up to date. And we can have a motion for adjournment.
So moved.
All in favor? Thank you. We'll see y'all